Hello, everybody, and welcome to our PrecisCa tumor board on multiple myeloma. Very excited about these cases and our panel. I'm Dan Pollier from the University of Colorado, and I'm joined by a really great group of colleagues here today to discuss these cases. And so each of us is going to introduce ourselves, starting with Dr. David Schuster.
Hi, I'm David Schuster. I am a radiologist and nuclear medicine physician from Emory University.
Hi, I'm Dr. Peter Forsberg. I'm a medical oncologist with a specialty in multiple myeloma at the University of Colorado.
Hi, my name is Ajay Nuka. I'm an associate professor at the Emory University Winship Cancer Institute. I specialize in multiple myeloma.
This is a 78-year-old Caucasian male with a stage 3 IgG kappa multiple myeloma, treated with bortezomib-based therapy and a kyphoplasty of T12 and L2. This patient relapsed after 7 cycles of this therapy and then began lenalidomide and dexamethasone and had a very good response. It says a great response despite neutropenia. And a similar case to the beginning in an earlier stage setting, in that this is a patient who's deriving benefit from lenalidomide but having cytopenias, here specifically neutropenia. How could we manage this, and could it be through the addition of growth factor support, or do we need to change therapies? So a little bit more specifics on this case. This is a patient who presented with 6 months of increasing back pain, anemia, elevated creatinine, performance status of 1. This patient had mild renal impairment over the past 5 years, along with limited mobility using a walker. And this is, again, a 78-year-old patient. No relevant social history or family history. Diagnosed January 2020 with a stage 3 IgG kappa multiple myeloma. The monoclonal protein 3.3 grams per deciliter, the beta-2 macroglobulin of 6.1. IgG was 3730, hemoglobin 9.7. The serum creatinine was 1.9. We're going to talk about the PET scan in a moment. The bone marrow biopsy showed 40% plasma cells. And the patient did undergo a kyphoplasty, and we'll talk about the treatment in a moment, but maybe let me just skip to the relevant PET images, and maybe Dr. Schuster, you can take us through these.
Yeah, I don't think one needs to have done a nuclear medicine fellowship to see these lesions. There are lytic lesions we could see both in the cervical spine with intense FDG uptake, also diffuse activity as well. I think that's most highlighted within the pelvis, where we see multiple extensive lytic lesions, many of these expansile with extensive and intense FDG uptake. So this is a patient with a large tumor load.
Great, thank you. And just going back really quickly, so the patient did have the kyphoplasty for palliative purposes and then was given 5 cycles of a bortezomib-based treatment. This resulted in immediate relief of the back pain and the ability to walk unassisted, which is a great outcome. And a response with respect to a decrease in the monoclonal protein, the IgG, hemoglobin improved, creatinine came down to near normal levels. So a very nice initial treatment outcome. However, as this disease does, in November 2021, the patient relapsed asymptomatically based on the serologies, essentially the monitoring of the patient. Monoclonal protein now 1.8 grams per deciliter, IgG 2320, hemoglobin down to 9.9, creatinine 1.4. And so, Dr. Nuka, can you just comment, patients such as this, this is, I think, a beneficial thing to catch the patient before they develop symptoms, since the symptoms here can be so debilitating. What's the sort of frequency or interval with which you see these patients or monitor them particularly a patient such as this who was off therapy?
So if you look at the number of myeloma patients, so if you have 30,000 myeloma patients in the US, more than 10,000 myeloma patients exactly fall into the same category at the time of diagnosis. So it is not a small number. We focus more on talking about treatments that probably are applicable to the other half, not most to the elderly and the frail patients, which really needs to be emphasized more and more. So the patient initially presented with the bone disease, anemia, and he got bortezomib and dexamethasone. So when a patient like this, if you're giving a good regimen that can control the clones definitely for a longer period of time and put them on a maintenance, a continuous treatment, the patient would not be relapsing as we see at this point of time. Now, just looking at the history, probably within the time frame from stopping the treatment to the relapse is short. And now we're talking about a relapse disease. And in general, when I look at a PFS1, the PFS1 is close to half of a myeloma patient's journey. So that prolonging that PFS1 should be the key in every single person. This is, again, my peeve to talk about where we could have done a little more or could have done a little better in this patient. Coming to the question of how often do I see these patients on coming on, monitor these patients in the clinics when they're off treatment every 6 to 8 months, specifically for the same reason. We did not achieve a complete response. We've achieved a good response with the initial induction treatment, and we're continuing to monitor them. And specifically, when the patients relapse, we looked at our data set to see how many patients present with a symptomatic relapse versus a biochemical relapse. So of the 445 patients that relapse, majority of these patients presented as a biochemical relapse first. So that is the key for us to see that, yes, you can measure these numbers going up just in the blood before a bony event happens and puts the patients at morbidity. So that's my approach to seeing those patients every 6 to 8 weeks. If the patient remains in a CR and that remission, that duration of when you can see, or the interval of when you can see, can be extended a little bit, but that's depending on the right patient that you see.
Great, thank you for that. So in this case, as you suggested, the close monitoring resulted in reinitiation of a second-line therapy. In this case, lenalidomide and dexamethasone was chosen. And we saw a nice response with respect to the decrease in the monoclonal protein. But as we pointed out before, this patient now becomes neutropenic with an ANC of 500. The dose is interrupted and filgrastim is added. However, there's continued neutropenia despite dose reductions of the lenalidomide and filgrastim support. So, Dr. Forsberg, what do you think about this case? Having a good response with respect to efficacy, but maybe some issues with respect to tolerability. Do we continue the lenalidomide? How do we mitigate this? Or do we need to? Or do we need to change therapies altogether? How would you approach this?
Yeah, I think it's a challenging scenario potentially. I think earlier Dr. Nuka mentioned in our other myeloma, other lenalidomide myelosuppression or low platelet case, the need to sort of make sure you understand what's going on with their disease. In patients who do have active relapsing or progressive or newly diagnosed myeloma, if you have low blood counts during your treatment, because of extensive marrow involvement related to the myeloma, if you don't continue along therapy and try to support patients through it as best you're able to, you'll never overcome those cytopenias. So I think best I can understand from this case, that's not exactly his scenario. As far as we know, this is a patient who's responding well, who should be having less marrow involvement, but is unfortunately having more myelosuppression that's limiting the ability to stay on therapy. And it's a little different than some of our other scenarios we talked about, which was the maintenance setting. This is a patient who's, not as much on maintenance as he's on active therapy for a recent biochemical relapse. So it isn't somebody where you would want to come off therapy entirely because of myelosuppression. It's somebody where you'd be trying to find a way to keep them on some form of therapy. And, Dr. Nuka sort of mentioned the importance we all feel about trying to be on treatment consistently. The importance of fairly stable therapy, particularly in patients who may have already declared from their initial features and short treatment-free intervals that they could sort of potentially, have with disease control, that they have some aggressive characteristics of their myeloma as well. So this is somebody that I'd be trying to keep on some form of treatment by hook or by crook. Now, I think the lenalidomide probably gets at, how much you've had to adjust dose. I think, there are, I think we can, I feel fairly comfortable reducing to, relatively low levels if we still see therapeutic benefit. I think the good thing about myeloma is we have a monoclonal protein that can tell us month to month to some degree what's happening with their myeloma. So, in this patient, my first goal would be to try to reduce the lenalidomide if they've had a good response, to try to keep them on that therapy. But if we reach a point where they are persistently severely neutropenic, with even low doses of lenalidomide, which is not the most common, but not an impossible scenario, then I would think of substituting something different, whether that's bortezomib again, which they stopped even though they were, having a sustained treatment response, so they should be eligible to be retreated with that with potentially good effect, or other agents like carfilzomib or daratumumab. We have a number of different therapies that could be brought into the mix. They may be susceptible to myelosuppression with other agents, but I do think you would want to try to keep them on some continuous therapy, first with dose reductions and then possibly substituting an alternative agent if you just couldn't reach a place where they can be safely maintained.
Great. Thank you for that. So I think in summary, in a situation where you have a patient such as this who is, responding well to therapy, but having some toxicity, the bias should be toward trying to continue therapy because, of course, the disease recurrence or the potential symptoms and consequences from disease recurrence are worse than some of the toxicities. Mitigate the toxicities with dose reductions if possible, and if not, switching therapies to a different maintenance approach would be something that we would prioritize.